Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Guys, we're continuing our review of the 2024 official ICD-10-CM coding guidelines. And I appreciate the comment I got from one subscriber. She said, Coach, thanks for the review. It's good to go back. She's already certified. She said, but it's good to go back and review these guidelines again. And I want to remind you guys, once you're certified, let me take it back. In school, you lived with your books. You studied these books. You knew everything in them to prepare for your exams. Now you got certified. You got your job. Are you staying current? Because you know as well as I do, when you get your job and you start working in an organization, let's just say you're working in an OBGYN office. You're staying in the 5 section of CPT. You're doing all of those OBGYN type diagnoses and procedures. What about dermatology, radiology, path and lab? Are you staying current? Or are you so busy working your job that you're not staying current? We've got to find avenues, whether it's a YouTube video, a class, whatever necessary to keep you in your books, keep you studying, because you don't know where you'll be tomorrow. Imagine moving from OBGYN and seeing a cardiology job. When last have you looked over the cardiology section of the ICD-10 or CPT book? How current are you? I hope this review helps you with this process. Okay, let me minimize my box and let's get started, because now I think you'll appreciate this review. Okay. We stopped at chapter 2, neoplasms, and those codes, the section is C00 through D49 of the ICD-10-CM classification. And I made a couple of notes. One, neoplasms have their own table, and it's behind the alphabetic index. That table will look very similar to this. This was just a screenshot of a book I had back in 2021. I'd taken a screenshot of the neoplasm table. And notice the table makes our ICD-10-CM codebook so much smaller, thank goodness, because imagine trying to put all of these and identify them as malignant primary or malignant secondary or carcinoma in situ, or benign or uncertain behavior or unspecified behavior for every single type of neoplasm. That would be a difficult job. But I'm glad to see that table. So look for that table behind your alphabetic index in your ICD-10-CM code books. All right, note 2, you must know the type of neoplasm that you are coding. When they say adenoma or sarcoma or carcinoma, if you don't already know that a sarcoma is a malignant neoplasm, you won't know what to look for on the neoplasm table. When you go to the neoplasm table, if it's a sarcoma of a certain body part, let's just say thigh, is it primary? Is it secondary malignant? Is a sarcoma in situ or benign? So you've got to know the behavior or the type of neoplasm that you're coding. And then based on the type, this will lead you to look up for the right neoplasm. So look up sarcoma first in your alphabetic index, and it'll tell you where to go on the neoplasm table. We'll talk about that a little more in just a minute. And then a note 3 that I wanted to add before we start reviewing the guidelines is there's a difference in benign, in malignant, benign, cancer in situ or carcinoma in situ, primary site, secondary site. So do your research. All these in purple are my little inputs that I'm adding to what I'm going to cover in the guidelines, and that's why I highlighted them in purple. These guidelines don't tell you this. Coach is telling you, do your research. Learn that malignant neoplasms are bad. They're invasive. They go into tissue and they eat. I think of a Pac-Man just eating away at the good cells, eating them up and destroying them. where benign is just a new growth. It's not invasive, it's not going in, it's not damaging tissue, it's just extra tissue, extra growth. Carcinoma in situ, now understand with in situ, that means it's confined. It stays at one place, but it's bad. It's malignant cancer that stays in one area. It stays confined, but it's eating it up. And then primary site is the first site that the cancer invades. And then cancer can spread. Metastatic or malignant cancer spreads to secondary sites. So again, do your research on the different types of cancer so that you better understand what you're coding. All right, and then the guidelines start with primary malignant neoplasm overlapping site boundaries. So let's look at the guidelines for primary malignant neoplasms overlapping site boundaries. And it just says a primary malignant neoplasm that overlaps two or more contiguous, next to each other, sites should be classified to the subcategory, which is a code .8, which means overlapping. So when you see this neoplasm coding, when you see that 0.8, you know that those sites were so close that the cancer just kind of spread, unless the combination is specifically indexed elsewhere. For multiple neoplasms of the same site that are not contiguous, they're not joined, such as tumors in different quadrants of the same breast, code for each site should be assigned. So each site of a breast, and they're not contiguous, are individually coded. All right. And I said, for an example of an overlapping would be intestines. Think of all, is it 22 or 32 feet of intestines in your stomach? Now, there are different locations in the stomach. I always did a tic-tac-toe in medical terminology, where I explained the iliac, the hypogastric, epigastric, etc., so that you can identify the regions in the stomach. But imagine those intestines from the large to the small, or small to the large. Because it can be contiguous, where you're identifying the sigmoid from the ileum, and they can run right into each other, and you almost can't tell the difference from where one starts and the next one starts. Those are considered contiguous. They overlap. And then malignant neoplasms of ectopic tissue. So when I heard this first, I was like, okay, I know my malignant, my benign, my in situ, primary and secondary, ectopic tissue. So I had to look up what is malignant neoplasm of ectopic tissue. And it said malignant neoplasm of ectopic tissue are to be coded to the site of origin mentioned. For example, ectopic pancreatic malignant neoplasm involving the stomach are coded to malignant neoplasms of pancreas, unspecified. The neoplasm table in the alphabetic index should be referenced first, because it does say neoplasm of ectopic or ectopic pancreatic malignant neoplasm. So I would go to neoplasm, but it's saying if it's involving the stomach, then you should code it to the pancreas, unspecified. So what is an ectopic pancreas? I've heard of an ectopic pregnancy, but an ectopic pancreas? It says an ectopic pancreas, often found during surgery or biopsy, is defined as an uncommon pancreatic tissue outside the normal pancreas, which lacks any connection to the normal pancreas and has its own vascular and ductal system. Okay, so what does ectopic mean? It's out of place, as of an organ not in its proper position, or a pregnancy occurring elsewhere than in the cavity of the uterus, of or relating to a heartbeat that has its origin elsewhere than in the sinoatrial node. And it says relating to ectopia, being out of place, having an abnormal position. Okay, I got a better understanding of malignant neoplasm of ectopic tissue. It's out of place. So let's see what the guidelines say about malignant neoplasm of ectopic tissue. Here it is. Malignant neoplasms of ectopic tissue are to be coded to the site of origin mentioned. Ectopic pancreatic malignant neoplasm involving the stomach are coded to malignant neoplasms of pancreas, unspecified. Now it makes sense. Okay, I got it. And they left a note. The neoplasm table in the alphabetic index should be referenced first. However, going back to what I said earlier, if the histological term is documented, that term should be referenced first rather than going immediately to the neoplasm table in order to determine which column in the neoplasm table is appropriate. They said, for example, if the documentation indicates adenoma, is adenoma benign or malignant? It says refer to the term in the alphabetic index to review the entries under the main term and the instructional note to see also neoplasm by site. And I did. I went to main term adenoma in my alphabetic index, not on the neoplasm table, in my alphabetic index. And it told me to see also neoplasm by site, benign. Oh, it's a benign tissue. The table provides the proper code based on the type of neoplasm and the site. And it's important to select the proper column in the table that corresponds to the type of neoplasm. The tabular list should then be referenced to verify that the correct code has been selected from the table and that a more specific site does not exist. So with that, it's just saying I want to emphasize here, histological term that describes the type of cancer, refer to that first. And so I wrote down a couple of them because I've seen adenosis, cyst, dysplasia, polyp. All of those could lead to a cancer or a neoplasm code. Also, think about other terms like non-Hodgkin's lymphoma. Is that benign or is that malignant? You have to look it up. Look up in your alphabetic index. If I said non-Hodgkin's lymphoma, look up the main term lymphoma and then go to the site non-Hodgkin's. Oh, and it'll tell you how to code properly. Or it might refer you to the neoplasm table and it'll tell you, go to neoplasm, this particular site, malignant primary. It will give you that much detail of how to look that up. Adrenal gland adenolymphoma. Is that a benign or what? How do I look that up on the neoplasm table? Adrenal gland adenolymphoma. We'll go to main term adenolymphoma and then adrenal gland, and it will tell you, see neoplasm, benign, by site. Oh, so that's what it's telling you here. The histological term is documented. That term should be referenced first rather than immediately to the neoplasm table in order to determine which column in the neoplasm table is appropriate. So I hope that helped. And that's why I put a note here. After you go through that, emphasize the yellow highlight that I put on these guidelines. I'm emphasizing that. That helps you know how to look neoplasms up. All right, and then admission or encounters for treatment of the primary site. Let's go to the guidelines. Here it is. Admission or encounter for treatment of primary site. If the malignancy is chiefly responsible for occasioning the patient admission or encounter and treatment is directed at the primary site, designate that primary malignancy as the principal or first listed diagnoses. The only exception to this guideline is if the administration of chemotherapy, immunotherapy, or external beam radiation therapy is chiefly responsible for occasioning the admission or the encounter. In that case, then assign the appropriate Z51 code as the first listed or principal diagnoses, and then the underlying diagnoses or problem for which the service is being performed as a secondary diagnosis. So if they're coming in for chemo, immunotherapy, or external beam radiation, then because that is the reason for the admission, the chemo, then that chemo code Z51 should be listed first, followed by the diagnoses that justified the chemo. All right, let's see what B says. Admission or encounter for treatment of secondary sites. Now your cancer has gone from one site, it's spread to a secondary site. It says refer to the guidelines. So we're at B. B says when a patient is admitted because of a primary neoplasm with metastasis and treatment is directed toward the secondary site only, the secondary neoplasm is designated as the principal diagnosis, even though the primary malignancy is still present. They're not coming in for that primary malignancy. They're coming in solely for the purpose of the secondary neoplasm. Then that secondary neoplasm becomes your primary code or your principal first listed code. Okay. All right, C, coding and sequencing of complications. Let's go to the guidelines. Now, these are complications. It says coding and consequences or sequencing of complications associated with the malignancies or with the therapy thereof are subject to the following guidelines. Anemia associated with malignancy. When admission or encounter is for the management of an anemia associated with the malignancy, and the treatment is only for the anemia, then the appropriate code for the malignancy is sequenced as the principal or first listed diagnoses, followed by the appropriate code for the anemia. And if you look up anemia in the neoplastic disease, it'll give you code D63.0. But what you're saying here is if the patient didn't have some other type of malignancy or neoplasm, then this patient wouldn't have anemia. But because of the neoplasm, they now have anemia. So we have to identify the anemia as such. And that's why we're sequencing the malignancy as the principal or first listed diagnoses. I hope I made that clear. That is the reason the anemia in neoplastic disease is the D63.0 is secondary to the malignancy code. All right, that's 1. 2, anemia associated with chemotherapy, immunotherapy, and radiation therapy. These are like anemia with radiation, chemo. It's those adverse effects. So let's look at the guidelines on this one. Number 2. When the admission or encounter is for management of an anemia associated with an adverse effect. Now, something went wrong. Adverse effect of the administration of chemotherapy or immunotherapy, and the only treatment is for the anemia, then the anemia is sequenced first, followed by the appropriate code or codes for the neoplasm and the adverse effect. It's going to be a T45 1X5, adverse effect of anti-neoplastic and immunosuppressive drugs. Because here you're saying, because of the treatment that the patient received for their neoplasm, for their cancer, now they've got a complication. They've got the anemia. So it's an adverse effect of treatment for the neoplasm cause your patient to have this anemia. It says, when the admission or encounter is for management of an anemia associated with an adverse effect of radiotherapy, the anemia code should be sequenced first, followed by the appropriate neoplasm code and code Y84.2, radiological procedure or radiotherapy as the cause of abnormal reaction of the patient or of later complication without mention of misadventure at the time of the procedure. So notice here, we're going to an external cause code. The Y84.2 identifies that had the patient not received this radiation, then they wouldn't have a condition or complication because of it. So therefore, make sure to use an additional code Y84.2. All right, let's move on to number 3, management of dehydration due to malignancy. So dehydration, here it is. When the admission or encounter is for the management of dehydration due to the malignancy, and only the dehydration is being treated, It says here, usually intravenous rehydration. And the dehydration is sequenced first, followed by the codes for the malignancy. Because again, they're coming in for dehydration, not the cancer, although it's because of the cancer that they have dehydration. Because they're only treating the dehydration, then dehydration becomes your first or principal listed diagnoses. All right, number 4, treatment of a complication resulting from a surgical procedure. Let's look at number 4. When the admission or encounter is for the treatment of a complication resulting from a surgical procedure, designate the complication as the principal or first listed diagnoses if treatment is directed at resolving the complication. Almost the same thing as number 3. Here again, they're coming in for the purpose of the complication. Therefore, the complication is listed first, is coded first. All right, now we're down to D. Primary malignancy previously excised. In this case, it's gone. The body part is gone. When a primary malignancy has been previously excised or eradicated from its site, and there is no further treatment directed to that site, and there is no evidence of any existing primary malignancy at that site, a code from category Z85, personal history of malignant neoplasm, should be assigned to indicate the formal site of the malignancy is no longer there. It's a history. So any mention of extensions, invasions, or metastases to other sites is coded as a secondary malignant neoplasm to that site. The secondary site may be the principal or first listed diagnoses with the Z85 code used as a secondary code. So again, if the body part, let's just say it was neoplasm of the breast, if you've had the breast removed and it's no longer there, patient is not showing any indications of any other neoplasms, then it's a personal history. If the cancer does spread, if there's another site with a neoplasm and it becomes the secondary site, we cannot say that the primary site is the breast because the breast isn't there. But they're coming in for treatment of that secondary site. Then we code that secondary site as our principal or first listed diagnoses, but we also need to identify that they have a history of, a personal history of a malignant neoplasm and identify where it was. Okay, so that's D. E, admissions, encounters involving chemotherapy, immunotherapy, and radiation therapy. It says go to the guidelines. E. Number 1, let me make sure I covered everything. Number 1, episode of care involves surgical removal of neoplasm. So here they're surgically removing it. When an episode of care involves the surgical removal of a neoplasm, primary or secondary site, followed by adjunct chemotherapy or radiation treatment during the same episode of care, then the code for the neoplasm should be assigned as the principal or first listed diagnoses. Okay, so here, if they're coming in for a surgical removal of the breast because of neoplasm of the breast, and then they receive chemotherapy or radiation therapy or whatever during that same episode of care, then it's considered that the breast cancer is still there. You'd still code it as neoplasm of the breast. Even though they're having the chemotherapy, radiation therapy after that breast is removed, they're still treating it. So as long as they're receiving active treatment for it, it's still coded as a current condition and not a personal history of. Hope that makes sense. All right, let's see what number 2 says. A patient admission or encounter chiefly for administration of chemotherapy, immunotherapy, or radiation therapy. So let's look at 2. If a patient admission or encounter is chiefly, and I highlighted chiefly, for the administration of chemotherapy, immunotherapy, or external beam radiation therapy, then assign Z51.0, as I told you earlier, encounter for anti-neoplastic radiation therapy, or Z51.11, encounter for antineoplastic chemotherapy, or Z51.12, encounter for antineoplastic immunotherapy as the first listed or principal diagnoses. If a patient receives more than one of these therapies during the same admission, then more than one of these codes may be assigned in any sequence. The malignancy for which the therapy is being administered should be assigned as a secondary diagnosis. And if a patient admission or encounter is for the insertion or implantation of radioactive elements, then the appropriate code for the malignancy is sequenced as the principal or first listed diagnoses, and then code Z51.0 should not be assigned. So again, this insertion or implantation of a radioactive element, when they're coming in for that, you still need the diagnoses to justify the procedure, which is implementation of radioactive element. Okay? Because you're justifying that procedure, then your neoplasm code goes first and then code the procedure. All right, that's 2. 3, patient is admitted for radiation therapy, chemotherapy, or immunotherapy and develops complications. So this should be interesting. 3, when a patient is admitted for the purpose of external beam radiation therapy, immunotherapy, or chemotherapy and develops a complication such as uncontrolled nausea and vomiting or dehydration, the principal or first listed diagnoses is still the radiation, Z51.0, encounter for antineoplastic radiation therapy, or Z51.11, encounter for antineoplastic chemotherapy, or Z51.12, encounter for antineoplastic immunotherapy, followed by any code or codes for the complications. And when a patient is admitted for the purpose of insertion or implantation of radioactive elements and develops a complication such as uncontrolled nausea and vomiting or dehydration, then the principal or first listed diagnoses is the appropriate code for the malignancy again, followed by any codes for the complications. All right, same rules apply here. Let's look at F, admission or encounter to determine the extent of the malignancy. All right, so let's go to F. When the reason for admission or encounter is to determine the extent of the malignancy, or for a procedure such as paracentesis or thoracentesis, the primary malignancy or appropriate metastatic site is designated as the principal or first listed diagnoses, even though chemotherapy or radiation therapy is administered. So here you're trying to find the reason to determine the extent of the malignancy. So you're doing a procedure to determine the extent. Then it's saying here, the appropriate metastatic site is designated as the principal or first listed diagnoses. That becomes it. That's F. And then G, symptoms, signs, and abnormal findings listed in Chapter 18 normally in our ICD-10-CM codebook that are associated with neoplasm. What's the guideline on that? G. Symptoms, signs, and ill-defined conditions that are in Chapter 18, characteristic of, or associated with an existing primary or secondary site malignancy cannot be used to replace the malignancy as principal or first listed diagnoses, regardless of the number of admissions or encounters for treatment and care of the neoplasm. So again, you could have nausea and vomiting, dizziness, headache, etc. But all of those are a result of the neoplasm. And that is why the neoplasm is always sequenced first. Had they not had the neoplasm, they would not have these signs or symptoms. H, admission or encounter for pain control. Now here, notice it says that this guideline, it's in a future guideline. It tells us to go to 1 C6. So it means we're going to cover this pain control management in a later guideline. Let's go to I. Malignancy in two or more non-contiguous sites. Remember earlier we said contiguous, where they join so close you don't know where one ends and the other begins. But this says when the malignancy is in two or more non-contiguous sites. So let's see what I says. A patient may have more than one malignant tumor in the same organ. These tumors may represent different primaries or metastatic disease, depending on the site. Should the documentation be unclear, the provider should be queried as to the status of each tumor so that the correct codes can be assigned. So here we just need that documentation that clearly states which one's primary, which one's secondary, or are both of these metastatic or what? Get that documentation. Now, next one says disseminated malignant neoplasm unspecified. That's J. And I was wondering, disseminated, the definition of disseminated is cancer that is spread throughout the body. It's a metastatic phenomenon. So let's look at J. Code C80.0. Disseminated malignant neoplasm unspecified is for use only in those cases where the patient has advanced metastatic disease and no known primary or secondary sites are specified. It should not be used in place of assigning codes for primary site and all known secondary sites. So just code when it's just spread, it's disseminated. Then use code C80.0. And again, disseminated means cancer that is spread throughout the body. K, malignant neoplasm without specification of site. When they didn't say where. Code C80.1, malignant or primary neoplasm unspecified equates to cancer unspecified. This code should only be used when no determination can be made as to the primary site of a malignancy. This code should rarely be used in the inpatient setting. And I think I saw that on the table. And I wanted to make sure the coders knew that there is on the neoplasm table, see right here down here where it says unknown site or unspecified, whether it's primary or secondary, there is an unknown. Okay, but disseminated is different. But this right here, C80.1, unspecified, you see where it came from? Right there, when it's the primary site is unknown. So you go to unknown on that neoplasm table. Okay, that's K. Let's see. What does L? Sequencing of neoplasm codes. Number 1, encounter for treatment of primary malignancy. So let's go to, if the reason for the encounter is for treatment of a primary malignancy, assign the malignancy as the principal or first listed diagnoses. The primary site is to be sequenced first, followed by any metastatic sites. All right, so we understand that primary is always first. Encounters for treatment of secondary. Okay, so number 2, when an encounter is for the primary malignancy with metastasis and treatment is directed toward the metastatic or the secondary site, then only the metastatic site is designated as the principal or first listed diagnoses, and then the primary malignancy is coded as an additional code. So again, they've got a primary site, they've got a secondary site, but if all of the treatment is generated to the secondary site, then that secondary site becomes your principal, but then also using an additional code to identify where the primary site is. Because you're saying this is secondary, so then the question is, well, where is the primary site? Oh, there's also a primary site here, but today the treatment is toward the secondary site. All right, number 3, malignant neoplasm in a pregnant patient. right, let's look at that one. When a pregnant patient has a malignant neoplasm, a code from subcategory O9A1, malignant neoplasm complicating pregnancy, childbirth, and the purpurium, should be sequenced first, followed by the appropriate code from Chapter 2 to indicate the type of neoplasm. Remember, I've always said pregnancy, childbirth, and the purpurium codes always take precedence over all codes when coding, because, and the way I always make myself believe that is because two people are involved, the baby and the mama. So it gives more prestige, more attention. So those codes always get coded first, but follow it with the code outside of pregnancy to give the specificity if it doesn't. We'll talk about that more when we get to pregnancy, childbirth, and the purpurium. But here, assign code O9A1, malignant neoplasm complicating pregnancy, childbirth, and the purpurium. That should be sequenced first. Number 4, encounter for complications associated with neoplasms. When an encounter is for management of a complication associated with a neoplasm such as dehydration, and the treatment is only for the complication is coded first, followed by the appropriate code or codes for the neoplasm. The exception to this guideline is anemia. When the admission or encounter is for the management of an anemia associated with the malignancy, and the treatment is only for the anemia, then the appropriate code for the malignancy is sequenced as the principal or first listed diagnoses, followed by a code for D63.0, anemia in neoplastic disease. And I always tell my students, when you see it identifying as a diagnosis in something else, usually that something else is coded first. They're really clearly stating with this code that the neoplastic disease is the reason for the anemia. So I can understand why that puts that code first. All right, number 5, complications from surgical procedures for treatment of a neoplasm. When an encounter is for the treatment of a complication resulting from a surgical procedure performed for the treatment of neoplasm, designate the complication as the principal or first listed diagnoses. So see the guideline regarding the coding of a current malignancy versus personal history to determine if the code for the neoplasm should also be assigned. So again here, if they're coming in for a complication of a history, so it might be a complication of the breast site where the breast was and it's no longer there, then you code the history of, but if they still have it, then you code it as a current condition. Number 6, pathologic fractures due to neoplasms. When an encounter is for a pathological fracture, remember pathological means the disease process weakened the bone and cause it to be able to fracture very easily. Neoplasms will do that. So when an encounter is for a pathological fracture due to a neoplasm and the focus of treatment is the fracture, then a code from subcategory M85.4, pathological fracture in neoplastic disease, should be sequenced first, followed by the code for the neoplasm. If the focus of treatment is the neoplasm with an associated pathological fracture, then the neoplasm code should be sequenced first, followed by a code M84.5 for the pathological fracture. So again, attention goes to whatever the reason for the admission is. All right, this is a long video. I'm going to stop this one here. We're going to continue. We still have current malignancy versus personal history, etc. So let me stop this here because I'm going to lose you guys if the videos get too long. And we're going to start right back at M. Okay, guys? Thanks. I'll see you in the next one. Hope these videos are helping, guys. I hope they're helping you. Don't forget to subscribe. Thanks.